We move to our next talk for the day. This talk is themed NCD Care and Equity and is titled Provision of Diabetes Care at Secondary Hospital Setting. We will listen to a video by Dr. M.S Seshadri. We invite Dr. Tambu to please moderate the session.
Good afternoon, all. It is a pleasure to hear my own teacher and mentor, Dr. Seshadri, giving a talk about his experiences in the Tirumalai Mission Hospital. So it's an honor to be chairing your session, and I'm sure there'll be many questions and it will be inspiring for all of us. Over to you, sir.
Dear friends, it is a pleasure to be part of the Medicine Annual Conference once again. Over the next 20 minutes, I'll be talking to you about how we can set up a good system for diabetes care at secondary level hospitals. Diabetes mellitus is a very common problem seen in secondary level hospitals, and considering that India is the diabetes capital of the world, this is hardly surprising. Diabetes may be the primary problem for which patients come to hospital, or often it's an important comorbid condition in surgical or gynecological patients. If diabetes is not handled properly, final outcomes are compromised. Individual diabetics and families need to know a lot of things. They need to learn and do all the things necessary to achieve good diabetes control. Now, this is called internal locus of control, in contrast to external locus of control, where they depend upon the doctors. To achieve this, diabetics and families should be empowered. Necessary education should be imparted by the healthcare team, consisting of doctors, nurse educators, and nutritionists. Information, education, communication plays a key role. Every encounter with a diabetic and his or her family should focus on appropriate education. Make the education very interesting and also verify if your instructions have been clearly understood by questioning them. 2 to 3 levels of prevention can be envisaged in diabetes care. You can prevent or postpone diabetes onset to those who are prone to diabetes. For families, the positive, pre-diabetic, those with obesity and insulin resistance are examples. You can achieve and maintain good glycemic control to prevent micro and macrovascular complications of diabetes. Even in those with these complications, we can prevent serious outcomes, say prevent foot ulcer, amputate those with feet at risk, or prevent or postpone onset of renal failure in those with microalbuminuria. The focus of management in diabetes, therefore, primarily on prevention. Recent articles talk about diabetes remission. Even those who meet criteria for diagnosis of diabetes can become non-diabetics and stay so for variable time periods by adopting rigorous lifestyle changes. This underscores the need to focus on this very important cost-effective intervention. To achieve cost-effective, successful diabetes care, focus on establishing 2 networks in your hospital. Within the hospital network consisting of doctors, diabetes nurse educators, and nutritionists. Within community network consisting of multipurpose health workers, volunteers from the community itself. Teamwork is essential to achieve good results. To establish the community network, you need to define the geographic area, the population to be served, establish rapport with the community, run simple small group discussions, survey households, economic conditions, customs, and practices, identify opinion leaders in the community and engage them, and through them engage the community. For example, the secondary level hospital in which I was working, Tirumala Mission Hospital, was caring for 35,000 families in about 315 hamlets, a total population of 160,000. We had divided this arbitrarily into 7 areas for administrative convenience. We need to establish a system for monitoring all diabetics in the community. You need to select a volunteer for, say, every 50 to 100 families, called family care volunteer or FCVs. This will be the nodal person or the channel of communication between the family and the care provider. The multipurpose health worker supervise the family care volunteers. One multipurpose health worker can supervise 50 to 75 volunteers. Conduct simple education sessions for MPWs and FCVs. This is called educating the caregivers. This represents our own structure in Tirumala Hospital. There were 452 family care volunteers working under 26 multipurpose assistants, and they form the key personnel who are responsible for the last level delivery of care. We need to empower family care volunteers and multipurpose workers by educating them on key aspects of diabetes. Repeated sessions are needed, and they in turn educate families. Teach these people basic aspects of diabetes nutrition, physical activity, how to check blood sugar, blood pressure, how to recognize hypoglycemia, how to identify feet at risk of ulceration, how to maintain individual diaries for patients. And they transmit this information to doctors and hospitals, can be done through mobile phone. And the hospital medical record is updated with the home monitoring results. Any dose modification suggested by doctors is actually conveyed to patients through the same mechanism. They also are taught how to identify sick patients requiring hospital admission and get them to hospital quickly. So this represents what was set up in our hospital. We have trained multipurpose assistants and volunteers who identify, educate, refer patients for treatment. At the hospital camp or in the hospital itself, the team examines and treats the patient. The patient is finally discharged and is followed up at home through multipurpose workers and family care volunteers. Intelligent use of the community network reduces hospital visits for patients, reduces time away from work, delivers care at doorstep, and empowers families to deal with diabetes in family members. Equipping the hospital for diabetes clinics is not very difficult. You need to run dedicated outpatient diabetes clinic with a nutritionist, nurse educator, and physician. You need to have a TV screen, computer screen with projection facilities for education, a dressing room for care of foot ulcers, pharmacy well stocked with essential drugs, metformin, gliptin, pioglitazone, sulfonylurea, SGLT2 inhibitor, insulin, and choose drugs that are relatively inexpensive so that they can afford. Need a 128 tuning fork, a 10-gram monofilament for testing sensation, an ophthalmoscope for looking at the fundus. At first presentation of a diabetic, characterize diabetes using simple clinical details. Diabetes in the young, those age less than 35, may be moody. If there is a 3-generation family history, you need to suspect this. Women with past gestational diabetes, again, you need to suspect moody. If a patient has weight loss, osmotic symptoms, but no ketosis, you suspect latent autoimmune diabetes in the adult. And the same symptoms above with abdominal pain and diarrhea, suspect FCPD. Alcohol habituation, you suspect pancreatic diabetes. If the patient has weight loss, osmotic symptoms, and ketosis, of course, it is type 1 diabetes. You may need additional tests, an X-ray of the abdomen, ultrasound, or CT to identify pancreatic disease if you suspect pancreatic diabetes. GAD antibody, fasting C-peptide if you suspect type 1 diabetes or LADA. And remember, all diabetics who lost a lot of weight recently need insulin as initial treatment. It's useful to have protocols for choice of oral hypoglycemic agents. First, find out how much the patient's family can afford. Tailor the prescription to fit their means is the only way to ensure long-term compliance. Find out what they can get free from the government hospital or PHC. Usually, they have access to free OHAs from government hospitals, and you can use that. Additional drugs, when required, can be prescribed. For example, glibenclamide, glipizide, metformin are available free from government facilities. The control is not good, can add on pioglitazone. Insulin is available from government hospitals, and those requiring insulin can avail free insulin from government hospitals. The weakest links in diabetes management in the community are two. One is poor understanding of the disease by patients and family. This can be addressed through MPWs and STBs as outlined earlier. And the second important thing is the lack of a system of monitoring. A system needs to be put in place by which blood sugars can be monitored at home, and this information can be transmitted to the hospital, and dose modifications can be conveyed to the patient. And for all this, remember, mobile phone penetration is excellent in our rural areas, and SMS or a phone call is a simple way to communicate with patients and families. You can arrange a telemedicine facility and arrange for a video call with a patient or a family member on a mobile phone. Why is home monitoring important? High blood sugar values often do not produce major symptoms, and unless monitored, periodic dose adjustment will not happen to optimize glycemic control. Knowing the blood sugar values on a monthly basis improves compliance with lifestyle measures on the part of the patient. Home monitoring reduces need for hospital visits and conserves productivity of the individual. Home monitoring system has widespread acceptance in the community. Those willing to enroll, 98 to 100% compliance can be achieved. And how do we deal with the cost? Patient bears a third of the cost. Please remember, anything given free is not valued. The rest can be subsidized by the hospital by having a dedicated fund for this exercise. Get donors from organizations, companies in the vicinity. Include employees of organizations, companies as beneficiaries as well. Many agencies are willing to donate as part of their corporate social responsibilities, and this can be utilized for setting up this network for home monitoring. An example of what we have been able to achieve in our own community, the 7 areas, all the enrolled patients, 100%, we have been able to successfully monitor in 3 consecutive months as shown here. And the same applies to blood pressure monitoring. We are able to achieve 100% monitoring at least once a month in all the subjects who had enrolled over this 3-month period. The patient and family need repeated intensive education on many aspects. The first thing they need to internalize is diabetes requires lifelong treatment and follow-up, and lifestyle interventions are for the entire lifetime. Good long-term control prevents postponed serious complications. They need to understand this very clearly. Every diabetic should know his or her ideal body weight, strive to achieve and maintain it. Details of the prescribed dietary modification, optimal physical activity, his her individualized blood sugar target. Remember, the blood sugar targets are individualized. It is not one cap that fits all. How to anticipate and avoid hypoglycemia, how to recognize and manage hypoglycemia, how to handle a sick day. So there are a whole lot of things that a diabetes needs to know. And I always say that diabetic needs to know as much about his diabetes as his doctor does. Education should also focus on cessation of cigarette smoking to prevent heart attack, stroke, and amputation, cessation of alcohol consumption to optimize glycemic control, avoid hypoglycemia, and avert pancreatitis, proper foot care and footwear to avoid foot ulcers and amputation. Insulin requiring diabetics need to know some more things: how to store insulin, how to inject insulin, site rotation to avoid lipohypertrophy, lipoatrophy, timing of insulin administration, minor dose adjustments depending upon meal size, use of insulin syringes and pen devices, how to monitor with a glucometer and maintain a record. The nutrition advice works well for the whole family. Remember, in If you identify a diabetic, there are other members of the family who may be at risk, particularly overweight children. It is difficult for families to have different meals for different individuals. Therefore, it might be a good idea to advise a diet that can be followed by every member of the family. Find out meal pattern, content and timing, and modify the existing scheme. Do not prescribe a diet that the patient and family just cannot follow. Newly diagnosed obese type 2 diabetes, you can consider intermittent fasting, that is, the last meal of the day at 7 p.m., the first meal of the day at 9 a.m. Now, if you opt to recommend this to a patient, avoid sulfonylurea at night time. Some useful tips: start every meal with a good helping of vegetables, reduce carbohydrates and increase protein, allow reasonable amount of fat, can go up to 30% of caloric intake, advise use of different cooking oils, get nutritional advantages of each type of cooking oil, emphasize that dietary advice is for the whole family. Physical activity, what is recommended, as you all know, is aerobic activity for an hour per day, flexibility exercise for 2 sessions a week, weight training for 2 sessions per week. How does it actually work for rural folks? A housewife who minimizes use of gadgets at home, maintains a kitchen garden, and walks to the shop for getting a daily provision, achieves all this. A milkman who tends to his cows, uses his cycle to deliver milk to his customers, achieves consistently all the recommended activities. Therefore, before recommending physical activity, find out about current physical activity, modify this to achieve targets. Encourage physical activity as part of daily life. Gardening, cycling, walking to work, for housewives, kitchen garden, minimizing use of gadgets. My mentor, Professor Jacob John, calls this productive physical activity. Now, managing inpatients with diabetes, you need to have protocols for management of diabetes and diabetic emergencies printed out and put up for ready reference to the hospital, so that all the members of the team know the basic protocol that will be used at that given hospital. And you need to organize a special clinic for gestational diabetes where the patient is seen both by a physician and obstetrician. Manage other risk factors for atherosclerotic disease, smoking, dyslipidemia, hypertension, obesity, all these require attention, and good control of all these is mandatory to avoid macrovascular disease. We often find diabetic renal impairment in the outpatient department, and many of these patients do not have edema or hypertension. They are dry and they are normotensive. These subjects, renal failure may be due to analgesic abuse. Remember, harmful NSAIDs like diclofenac are available over the counter in our country. Patients often get and use these for pain relief and get into trouble. Educate patients about avoiding such nephrotoxic drugs, but provide an alternative, say paracetamol. In difficult to control diabetes, you need to think of exogenous steroid intake. They're very common in those with chronic skin disease, respiratory disease, or joint problems. Corticosteroids are also, unfortunately, available over the counter in our country. Once they find benefit, patients continue to use these long term. Look for clinical features of Cushing, proximal weakness, purple striae, hump over the back of the neck. If you suspect these, check an 8-AM cortisol, usually suppressed. And in this situation, use non-steroidal anti-inflammatory drugs as alternatives for the basic problem. You may have to cautiously withdraw steroids to optimize control of diabetes. Complication screening needs to be done once a year. Macrovascular complications can be assessed by checking all peripheral pulses, listening for a carotid GOE, checking blood pressure in all 4 limbs, inquiring about claudication, angina, and dyspnea. If needed, you may do an ECG and you may need a cardiology referral in patients who have recent onset dyspnea or chest pain. A fasting lipid profile to ensure optimal lipid control is essential as part of the annual follow-up. De-emphasize nutrition, physical activity, and re-emphasize targets for glycemic, lipid, and blood pressure control. Microvascular complications, you can just dilate the pupils and do a fundus examination, and you will be able to decide whether an optional consultation is required. Do a monofilament testing with a 10-gram monofilament, check vibration with a 128 tuning fork. You will be able to identify feet which have torn, callosities, deformities, which are indicators of feet at risk for ulceration. And once you identify at-risk feet, intensive foot care education and footwear advice are mandated. Do a urine protein creatinine ratio, serum creatinine and eGFR once a year. Urine microalbumin if feasible. Ensure angiotensin converting enzyme inhibitors and ARBs are used in those with microalbuminuria to prevent progressive renal damage. Diabetes management in the community can actually be streamlined. It is possible to provide good care for all diabetics in the community. The approach that I have outlined, if followed, can help to minimize costs and maximize benefits for patients and their families. Thank you very much for a patient listening.
Thank you very much, sir. That was a recorded talk by sir. Sir is available online for question, and if anybody has questions, you can either put up your hand or you can send the questions up front. Sir is online. Sir, one question for you. Sir, could you comment on the impact of the MTM scheme on patients with diabetes mellitus? I'm not very sure what is the MTM scheme. Makkal Thedi Maruthuvam. So did you have on diabetes?
Yeah, I heard a detailed presentation of this by Dr. Sudarshini in the morning, and she was also very gracious to let us know that their own monitoring of the system has identified several fault lines that are there. In particular, the fault lines are an inability to monitor patients long-term in the community, and inability to maintain individual records, and to keep a handle on what is happening to individual patients. These are all vital for achieving optimal diabetes control for diabetics in the community. So what we have tried to do is actually utilize what the government already does, but in addition, provide for plugging the loopholes that exist in the current system. If the MTM scheme actually improves considerably and addresses all these issues, it will be a fantastic scheme for Tamil Nadu.
Sir, another question. Family-centered care, have you been able to influence families to take care of their family members with diabetes? What has been your experience?
We have been very, very happy with the way families react to our educational exercises for whole families. We don't teach just the diabetes. We have families getting together, and the instructions actually are for all family members. As I told you, everything works if you consider family as a unit, whether it is nutritional advice or whether it's activity regarding physical exercise. See, physical exercise is not just for the diabetes, right? If there are obese children in the household, it is meant for them too. Okay, so you emphasize the concepts for the whole family, you get a far greater benefit than just educating individual diabetes. So our unit for education is actually families and not individuals.
Sir, another question. Your comment on lean diabetes and your experience with that in the community.
Yeah. We see a pretty large number of lean diabetics where I work, and most of them actually require insulin. All right. This is something that is not well appreciated. If they don't get insulin early enough, and if the control is not maintained properly, they get into complications much earlier. So the so-called lean diabetics in the community with very high blood sugars should be receiving insulin either right from the beginning or at some stage when control is found to be very suboptimal with oral drugs. I acknowledge the fact that there are some lean diabetics who are well controlled with oral drugs. I'm not talking about those. I'm talking about lean or non-obese diabetics with very poor glycemic control. Those individuals definitely require insulin, and earlier it is started and adjusted, the better for them.
A lot of questions. I hope you don't mind. Should the
problem.
government replace rice with millets?
I think it's a question I raised during that session with Sudarshini. I don't think it was raised. Actually, there are several things that the government should do. It is a very important thing to realize that the Tamil Nadu government has actually recognized the importance of the millets in the year of the millets. In fact, there was a budgetary allocation of nearly 70 crore for farmers for growing more millets. And there was some talk about replacing at least part of the rice that is being distributed by the public distribution system by millet. When that happens, I think it will be a very good step. But it is not enough if you introduce millet, but you must find out, these are things that are very well accepted in the rural community. When we spoke to our community about use of millets, they were very ready to accept it. In fact, they came up with recipes which we put up in a book and circulated. So they are quite enthusiastic about it because number one, it cuts down for them a cost. Number two, they don't get into severe hypoglycemic reaction. Rice-based meals, the sugars go up and come down very quickly, whereas with a millet-based meal, the sugars don't come down that fast. So hypoglycemia is much less of a problem. So they do readily accept, diabetics readily accept this, but it is important that it is made available in an equitable manner by the government through the PDS.
Sir, a couple of more questions. Have you seen diabetes remission in the community? Is it a common thing to see that? Do they follow lifestyle and go into remission?
I have about 4 patients who have achieved this. Okay. These were youngsters diagnosed with diabetes. They were all overweight and they actually went on this intermittent fasting that I alluded to as part of their thing, and also went on very regular physical activity and trimmed down. Basically, the remission was due to lifestyle measures, and they did not want to take medication. Once they learned that lifestyle measures may be able to achieve this, they spent effort on it and went into a remission. And one of them has actually relapsed. Okay, so I'm careful to use the term remission rather than a cure. It's not a cure. It's a remission for variable periods of time. In fact, milk vendors who have taken to a motorized two-wheeler for distributing milk, when they revert back to their traditional cycle for distributing milk, they achieve a remission. I've seen this happen, right?
So one last question. I think it was alluded in the morning talks as well. Do we need to have an endocrinologist in situations like this? Is it good to have is that an essential part of a community-based program like this?
Now, I think physicians trained in endocrinology is more achievable than people with a qualification in endocrinology, DM qualification. So I think the model that was that Sijoy proposed, have somebody who did MD in internal medicine come and do a fellowship program in endocrinology in a center like CMC. So that he is quite aware. He is as well trained as any other endocrinologist in the department. But he takes this back to where he is working. And that adds a really great dimension. I think it's the same thing that Philip Finney did when he was working in Rexall. He took his skills there and he was able to change many things there. I think the 2 things he worked on, one was steroid use in the community, and he got a lot of awareness about that in the community. That was a very creditable job.
So one more last question, sorry. Health systems to keep clinical information. Do you have a well-developed health information system for the whole community in your hospital to
Yes,
monitor the health?
right. You're right. We do have a comprehensive record for all the families that are available in electronic format. It is a challenge to keep it updated. It's not the initial part, getting everything in is easy, but updating it periodically is something that is a big challenge. Okay, so this is something that we are working on, and it requires a lot of additional work to keep updating what is happening. But we do have a basic health information system for the community that we serve. Even though not all the subjects in the community seek medical help in our hospital, we do know what is happening to each family.
Sir, thank you for spending your time with us. We are deeply honored. Thank you very much, sir. Let's give Dr. Seshadri a hand. Thank you to the organizers for asking me to chair this session. And with that, I'll hand over. Thank you, sir.
Thank you. Thanks a lot.
We would like to especially thank our speaker, Dr. M.S Seshadri. Thank you, sir. We'd also like to thank Dr. Thambu David. Thank you, sir, for moderating the session.